bit of our time, but it is well needed. We need to find ways in which we can grow that regional tourism within our region in East Africa. How about now we get back to our conversation and I introduce to you our guests on the show today as we talk matters breast cancer. It is Breast Cancer Awareness Month, and as we finish off with the month of October, it is only right for us to get to have a conversation on how we can create awareness and get to also honor those affected by breast cancer. And joining me is none other than Dr. Abeid Athman, and he is a consultant clinical oncologist and the head of Oncology department at the KUTRRH. Welcome to the program.
Thank you, Vivian, for the warm introduction and the warm welcome you have afforded me here. As you had introduced, my name is Dr. Abeid Athman. I'm a consultant clinical oncologist. That means I deal both with medical and radiation. I'm also the head of the Oncology department at the Kenyatta University Teaching Research and Referral Hospital. Thank you for having me.
It's a pleasure to have you. Now let's get straight into it. When you talk about breast cancer, you know, I know it is one of the leading causes or rather one of the leading cancers in Kenya, specifically to our women. Now, when you talk about it, what should we look out for in terms of the early signs of breast cancer?
Okay, thank you, Vivian. This is a very important question because we are facing a very huge challenge. Recently, a lady came to me saying she was doing her usual checkup. Then they picked a lump, and she was asked to go ahead to go and perform proper screening, which is with the mammogram, to confirm whether this lump is going to be cancerous or not. What most people don't understand is most of the lumps, they are not cancerous. Just a few of them, they are going to be cancerous. So one of the common signs of breast cancer is breast lump. So unfortunately or sadly, she didn't go to hospital. I asked her why you didn't go ahead to do the screening to confirm if you have breast cancer or not. Because that time when it was seen, it was extremely small. So by the time she went to the hospital, is when she was having some pain. It means you have already delayed. So when we talk about screening, it means you don't feel any signs. We are the one looking for it. We capture it so that it can lead to better survival, because we know that early detection saves lives. And this is the reason why in America and in Europe, there are women, they are living longer, being diagnosed with breast cancer. They even forget like many years, like have been diagnosed with breast cancer. You see people living their 20 years, 30 years, 40 years. That is entirely whole life of a woman, just because they go early doing the screening and early detection. So sadly, this woman, by the time she came, the cancer has already spread, gone all the way to the armpit and everything. This is somebody who has insurance. This is somebody who is well educated, aware, but she said the lump didn't have pain, and this is what I would like to pay attention. So when we talk about breast cancer, these lumps, they are painless. And this is where most women go wrong. It's a painless breast lump. So you're not going to experience any pain. By the time you are going to experience pain, it has already progressed, like an increase in size, maybe even go all the way to the armpit, because usually it follows the channel where it drains the lymphatic system. So usually it follows an order. Most will start from the breast. After that, it will go to your armpit. From the armpit, then it can spread anywhere. So these lumps, we need to pay attention. We need to pay attention is painless breast lump. So this is problem number one. It is painless. So most women, they are missing it. Problem number two, usually most women focus on the breast, on the middle part and the front part. But majority, but not all, of the breast lump, they occur towards the armpit. So what we call the breast tail. Most people, they may not understand, the bulk of the breast is located towards the outside, towards your armpit, the bulk of it. Like, let's say, up to 60–70%. What you have internally is just a small part. That's why when you sit as a woman, you always look at yourself, you'll always look at your breast, they are facing, nipples facing outwards. Why? Because bulk of the breast is outwards, the ligament is trying to support it not to fall. That's why you see them facing outwards because of the heaviness of the breast. So number one, painless lump. Number two, the lump is located from the outer quadrant, what we call the axillary tail. So most people miss it. So we need to pay attention when we are checking ourselves, also to check near the end of the breast and the armpit. So this is the most common sign. The other sign, and I've seen is now becoming more common, most women, they might not notice the lump in the breast, but they will notice as the first sign when it has gone to the armpit, the axilla. So this is already delayed. So by the time you go, it goes to the axilla, is already delayed, because it means the least you can be is either late stage 2, stage 3. So when it is only in breast, most of it is stage 1, depending on the size. So the lump again, breast, armpit. Number two, the other common sign, you can see your nipple is going to go inside, what we call nipple retraction. Why are we having nipple retraction? Because the breast lump is pushing on your ducts, so making the ducts coming inwards. So you're having that nipple retraction. That's why you're going to experience nipple retraction as one of the early signs. As it grows, one of the breasts is going to shrink, the affected one. It becomes a little bit smaller. Usually it shrinks, becomes smaller compared to the other one. So looking at the breast sizes, comparing them, the symmetry, in terms of the shape, in terms of the size, it helps you to understand whether this breast is normal or abnormal. So nipple retraction, change in the breast size, and as it advances, it can now become what we call peau d'orange. It's a French word which means the peel of the orange. Like sometimes, you know, when you are hit with cold, you have like those goosebumps. So the same can happen to your breast. It appears like as an orange. So usually this is a very aggressive type of breast cancer. It means it has already spread to the skin of your breast. It appears like an orange. And this is a very big challenge, because usually they are very aggressive, and it is one of the most aggressive type of breast cancer. Now the biggest problem we're having with this type of appearance of breast cancer, it's very difficult to differentiate it with a woman who is breastfeeding is infected. So sometimes a woman who is breastfeeding, the breast can become engorged, it become infected, then it appears like an orange peel. But remember, with breast cancer, most of these women, they are not breastfeeding. So when you go to hospital, giving an antibiotics only to appear for that, it means you have to be very careful. That antibiotics you could use maybe just for a week. After that, no response, you need to go for further diagnosis. Don't say like it's the infection you're having, because infection usually is cleared very fast with antibiotic when it goes to the breast. Those antibiotics are working very smart. So appearance of the orange. Then as it grows, and this is what we are seeing in Kenya in most of the women, it becomes ulcerated, it forms a wound. So once it forms a wound, it means this cancer has already gone to your armpit, and maybe has even left the breast and the armpit, gone to the other part of the body, what we call stage 4 or distant metastasis. So now it brings us to the next signs and symptoms. These are they are already distant disease. Number one, depending where the cancer has spread, the patient can come with the only sign coughing as the early sign, because maybe they didn't notice anything in the breast, in the armpit, it has gone already to the lungs. This person is coughing, taking all forms of antibiotics, taking all forms of anti-cough drugs, and everything is not improving, only for it to be looked at, be seen as metastasis to the lungs. Here is another problem. If the clinician doesn't have good knowledge about breast cancer, or doesn't know this patient was having a lump in the breast, this might be treated as pneumonia, or it might be treated as TB. So we have seen a lot of patients being treated for pneumonia and TB, which is not improving, but it's either lung cancer or breast cancer or any other cancer which has spread to the lungs. The other part which the cancer can spread is goes to the bones. So the first sign to this patient would be like back pain. So you'll be taking all forms of painkillers, go for your massage, do everything, but this pain is not improving in your spine, in your back, in your bones and everything, because it is cancer which has spread. You have to treat it right for it to be healed, to have the intensity of the pain going down. So this one can also become one of the signs. The other sign is like having yellowness of the eyes, and this means the disease is already very advanced. It has already spread all the way to your liver, because we know the liver is the engine. It does a lot of work, digestion, detoxification, everything. So because the liver is overwhelmed, it now make your eyes appear yellowness, because usually it clear that yellowness from your body, take it to urine or take it to the stool. That's why you see the color of your urine is always yellow, or the color of your stool is somehow yellow. So if the liver is overwhelmed because of cancer spread in the liver, then the early sign can be just having the yellowness of the eyes. To worst, it goes to your brain. Once it goes to the brain, the first symptom the patient might come is having convulsions. So you might see this patient convulsing, and you might think like maybe other causes of convulsion, maybe it's just the cancer has spread. So if the hospital they have gone, or the patient cannot afford to do a brain MRI or even a CT scan, this will be missed, will be labeled epileptic, and this patient is not epileptic, it's just cancer which has spread. The bad news about cancer, it can spread to any organ, it can go nowhere. We usually say it didn't go to school, so it doesn't follow any pattern. So it can go any direction. So these are the most common signs of breast cancer usually the women experience.
All right, very well explained, and it's really interesting, you know, and the fact that if you miss it from the very first stage, then you're doing yourself a disservice, because now you're allowing it to go anywhere else in the body, which is quite unfortunate. So when we talk about early detection, that means early screening or constant screening. So how often should one be going for this screening? And is there a particular age, you know, from what age should we start going for these screenings?
Thank you, Vivian, for this enlightening question. Screening means you are looking for something which you cannot see it. That's why there's a screen. So you're trying to screen it, look for it. Just when you go to the airport, they pass it, then think, oh, you forgot, you have your watch, you go back. You forgot something, you have a belt, it rings. So the same. When it comes to oncology or cancer screening, is the same. You don't see it, you don't know you have it, so once they screen it, they say, oh, there's something wrong over here, we need to take care of it. So it means screening, you don't know you have it, you don't know. And this is what we need to be doing. We need to go to the hospital when we don't know. Because when we go to the hospital, we pick it early, we are able to treat it. Number one, the cost of treatment is very small, then the survival rate is very high. So these two things, we need to have them in mind. Survival, cost of implication in terms of treatment. So which age are we supposed to do screening? In Kenya, most women, they are being diagnosed with breast cancer at the age of 45, 50. Let's go to the US. The average age of diagnosis of breast cancer is 55, 60. So it means our women are diagnosed with breast cancer at a very young age compared to Europe and the USA. It could be genetic, it could be environment, it could be now we are adjusting to the Western culture, so it is hitting us very hard. There's a genetic modification happening leading to this cancer. So in Kenya, with our guidelines, we have dropped the age of screening to 35 years old, whereas in many countries is 45 or 50. But in Kenya, it has been dropped all the way to 35 because we are seeing a lot of young women. But this screening will depend on your age. So for women who are coming at a very early age, less than 40 years, usually we screen using ultrasound. Why are we using ultrasound? And we know ultrasound is not the screening tool for breast, because most women at this age, they have very dense breasts. So mammogram is not able to differentiate between a cancer and normal breast tissue. So first we do breast ultrasound. Of course, we have already examined with our hands. We can able to feel the lump is there or not. Then after that, we do ultrasound. But the standard tool of screening breast is mammogram. This one has been validated, and it has been shown to improve survival in terms of breast cancer survivorship. So age of 40, mammogram. Anything less than 40, we are going to do ultrasound with a complementary clinical breast examination. Clinical breast examination, it means me as a physician, I'm going to examine you, your breast. The one you do it yourself, we call it self-breast examination. So there's a difference. Then again, when it comes to this mammogram, we usually classify them into two. Number one, the mammogram which we are looking for the lump is called screening. But when you already come with the lump, we call it mammogram. Remember I said less than 40, we are not going to do mammogram. But when it comes to diagnostic, we are going to do mammogram because we already know the lump is there, so we need to characterize to see if there are any satellite lesions, any satellite lumps are missing. Sometimes, even with this mammogram, you cannot able to see it. We now have a modern technology, we call it tomosynthesis. This is a type of a mammogram, like it's been designed like a CT scan. It cuts slice by slice, so it behaves like a CT scan. It shows very dense breast. We can even pick small lesions in the breast, and it can guide us where to go and take a biopsy, so we can ascertain whether this is cancer or not. Again, if this one cannot help, we also have the option of MRI. So MRI, it is also the standard tool for doing screening in women who are young or they're having very dense breasts. Also for women, they have a history of cancer in the family or having BRCA mutations. So BRCA is a kind of gene which helps us not to get most form of cancers, in particular breast. So once this gene is running in the family, it means the family has high risk of getting many types of cancer, which include breast cancer, ovarian cancer, pancreatic cancer, and in male prostate cancer. So nowadays, when this patient come to hospital, the first thing we ask, are there any history of prostate cancer, breast, ovarian, and even pancreatic, because we know now they are interconnected. So you can see the family members are having. So these women, we usually prefer doing mammogram, not mammogram, MRI. And if the age of screening is 40, we are lowering it lower by 5 years. So if we are starting at 40, we go to 35. If you're starting 35, we go lower at 30. So these people having strong family history of breast cancer and confirmed BRCA mutation, then we start the screening at an early age.
There's also this other question that I had, prompted off air, whereby, for us as ladies, most of the times when during our menses, there's the symptom of our breasts, feeling very, quite painful. Sometimes it's very sensitive when it's during your period time. Sometimes you feel like there's a heaviness, you might think it's a lump. So where do we differentiate between this could be cancer and this is just, it's just that phase of your menstruation? Yeah,
thank you, Vivian. Actually, this is a very valid question. Most women, they do ask and they are worried and concerned. But this feeling of feeling the tenderness, it appreciates the woman being a woman, because it's what differentiates between a woman and a man. Because the amount of hormones a woman experiences, the surge of the hormones, the progesterone, the surge goes very high. It makes the breast engorged and everything, because you are being prepared for two things. Either to become pregnant, that's why the breasts are becoming tender and huge, because they're preparing you for breastfeeding, or it's preparing you for having your period if you're not going to become pregnant. So at this time, the body is preparing your normal womanhood. So that's why the breasts become very tender, they become very engorged, very large and painful. Because of this, you are not able to feel well and appreciate any changes in your breasts. And because of this normal physiology, we usually don't encourage to do any form of screening. We usually let you to go undergo your normal physiology, to pass through your normal womanhood, so that we don't interrupt it, to make it like a very bad experience for you. So usually we recommend do screening at least 7 days or 10 days after your normal period. You can go ahead and do either self-breast examination. If you go to the hospital, they do clinical breast examination or even screening. Because that mammogram, it could be very painful. Remember, the breasts are squeezed. So imagine you're already in your periods, the breasts are tender, somebody's squeezing. It will be a very bad experience. You'll never want to come back again for screening because you're asking yourself, why am I going this torture? Let me just get that thing. If it comes by bad luck, and that's it. So screening for these women, don't do it during your period. Wait for 7 to 10 days after you have finished your period, then you can have your screening. Okay, so you don't advise for screening when someone is in their periods. Wait until you're done with your period, 7 days later, then you can go do the screening. Exactly. All right, that is very well put. Now, what are maybe some life factors that can help in lowering, the risk of developing breast cancer? Since what we're doing here today is mainly to spread awareness. So we're trying to look at ways in which,
if there is any, in which you can be able to just lower your risk of getting breast cancer? Ama ni bad luck too, you can get it however much you try and protect yourself.
I can call it bad luck. I can call it as part of life, part of aging, part of like a normal way how God has created it. The number one risk factor of getting breast cancer is being a woman. You being a woman is already a risk factor.
Wow.
But now a question to you, Vivian. Do men have breasts?
Yes.
Yes. So men do have breasts. So men can also get breasts. But because of very high hormone, of estrogen and progesterone, women are at higher risk of getting breast cancer compared to men. So in the overall prevalence and incidence of breast cancer, men is 1% in the world. But here in Kenya, we are seeing it very high. I can put it at 5%. Compared to Europe and America, where it's 1%, in Kenya we are seeing it 5%. The 95% is the women. So number one risk is being a woman. You cannot change it. Number two, the family you are born. You cannot change it. If you're born in a family where people are diagnosed with cancers, be it breast or anything, you cannot change it. That's fate already. You cannot do it. But sometimes we see some women, they do what we call prophylactic mastectomy. The famous Angela Jolie. So Angela Jolie, her family members were diagnosed with breast cancer, and it was BRCA. You remember I told you BRCA is the gene which is stopping us from having breast cancer. So Angela Jolie, after she saw this, what she did, she went ahead to remove all her breasts. So it is called lowering the risk. So even though you are born in a family with breast cancer, but you can also lower your risk by doing bilateral mastectomy, we call it prophylactic. Even for some women, by any chance or due to any other reason, whether they had some issues in their pelvis, they underwent the removal of both the uterus and the ovaries. So we know it also reduced the risk of cancer. Why? Because remember, the estrogen is being secreted and being released by the ovaries. So it is, you can also reduce your risk by doing oophorectomy, that is the removal of the ovaries. So family. Then now we have other risk factors. Being diagnosed with breast cancer is another risk of getting breast cancer. What does this mean? If you are diagnosed once with breast cancer, maybe it might come to the other breast, contralateral breast, or it can go anywhere. So being diagnosed with cancer itself is a risk factor for breast cancer. Now let us look at the things which we can change. Obesity. So obesity is a big problem. And it's a growing problem. That's why the industry controlling the obesity drugs is growing up very high. Because nowadays we are too lazy to walk. We eat a lot with little physical activities. Me and you, where we grew up, we used to walk a lot. Matate, I know you used to walk a lot, either to go and fetch water or to go to school. Myself, when I grew up, I used to walk going to school and everything. But here we are nowadays. Border, work, work, border, bus, school, to work, back to home. So everywhere we don't do any physical activities, no movement. This moving helps stimulate your physiology. It burns the fat. It regulates the hormones. So most people, they're not doing hormonal imbalance, dealing to obesity. So obesity itself, because we know that, especially after menopause, the fat become your source of estrogen, putting you at a very high risk of getting breast cancer. So obesity is a big problem, especially for women who are postmenopausal. For the women who are young, it might not be a big factor. Some people say it is protective. How protective? I cannot go into details. Okay. The other thing is alcohol. So alcohol is a very big factor leading to breast cancer because of the hormones imbalance, leading to obesity and many other risk factors. Again, cigarette smoking is also a risk factor. So these are the most common risk factors which we can modify. Physical activity, obesity, alcohol intake, and cigarette smoking. There are some contradictory information about hormones replacement. It also leads to breast cancer, so it can also lead to that. So if you have a family history, hormonal replacement, you need to follow up very closely to ensure it does not lead to breast cancer. So basically, these are the most common ones.
All right.
Of course, we have many more.
There are many more.
Yeah.
Okay, now we need to also honor and just also give hope to those who are already affected or infected by breast cancer. So for those who are already, they do have the breast cancer as we speak right now, what are the treatment options available, and how can you breathe hope into them? You know, for the longest time, cancer has been viewed as a death sentence, but I know that treatment options have been modified over the years, so it's not necessarily a death sentence. So if you can just, you know, speak about the treatment options available for those affected.
Okay, thank you. Actually, I would like to thank the government. They are doing an amazing job when it comes to the fight of cancer. Why am I thanking them? Compared to many countries in Africa, Kenya was ranked #1 in terms of breast cancer screening and management in the whole of Africa by WHO. Okay. So it means we are doing a lot of work in terms of policies we are making, in terms of the screening. We are ranking very high after South Africa in terms of screening, also in terms of treatment, people going for treatment, but it's still not there where we want to go. The other thing what the government has done, it has created what we call regional cancer centers, and this is what I really want to emphasize. Most people are not aware of these regional cancer centers. In Garissa, we have a fully fledged regional cancer center. It has everything what you can get in Nairobi, it can be done in Garissa. So for people living in Garissa, Mandera, Wajir, Meru and everything, they don't need to come to Nairobi. Everything can be managed in Garissa. In Mombasa, again, we have a regional cancer center where it has state-of-the-art radiotherapy machines, and they have 2 machines. So it means the government is doing an amazing job to ensure that the people are being treated, but still most people are not aware. You'll see people either coming to Nairobi, abroad, going for treatment. Nakuru has a regional cancer center, again with 2 machines, state-of-the-art machines, which you cannot even find in some of these big private hospitals. You can't find those machines. They have very advanced machines treating patients there, but people again are not aware. Then, of course, we have now the referral hospitals. The KU Referral Hospital being a flagship for the government, focusing mainly on cancer. At KU Referral Hospital, where I work, 80% of the activities, they are cancer related. And we are the only public institution which has a state-of-the-art imaging system, what we call PET scan. PET scan is a form of diagnostic imaging where you can be imaged at once from head to toe, and it can tell us if there's any cancer anywhere in your body. Before, people used to travel all the way abroad to go for this kind of PET scan. And the good news, we have it here in Kenya, and it is fully covered by SHA. You don't need to add any penny. So, yeah, because now you're cutting the cost of traveling, you're cutting the cost of michango and everything. We have here the services. Besides KU having this PET scan, Nairobi, it is leading in Africa. Nairobi is leading in Africa, having 5 PET scans. 5 PET scans, they are available in Africa. So we see a lot of patients coming from Rwanda, Burundi, even Tanzania. Until the beginning of this year, they stopped coming because they now have their own. And all these countries in sub-Saharan Africa used to come to Kenya because of this imaging. Then, in KU Referral Hospital, we also have state-of-the-art radiotherapy machine, which we call CyberKnife. CyberKnife is a form of radiotherapy where it treats with a very high precision, and it is the only machine in the whole of sub-Saharan Africa. So why should you travel abroad if everything can be taken care of in Kenya, paid by SHA? You don't need to go abroad. So any cancer which maybe has spread to the brain, gone to the lungs, or small, it can be treated very well in terms of the CyberKnife. And also we have some other centers doing another form of SRS, also available in Kenya. So we have a lot of treatment availability in Kenya, but awareness. People are not aware of this treatment. Usually when I see like flyers going all around, contribution, michango here and there, I usually feel very bad. Because some of these things, we have them available in Kenya. Most of it can be covered by SHA. Of course, SHA has its own challenges, but we know most of it can be covered by SHA. We hope the government is working on it to enhance. I know there's a committee which has been formed to enhance, to ensure our patients are being taken care for, and this is good news to our patients. So the other forms of treatment, for example, at KU Referral Hospital, through the Max Foundation, we are giving free cancer treatment. This is the state-of-the-art medication where you go to USA, you go to Europe, you are going to be given if you're having hormone receptor positive. This drug is over 300K per month. At KU, we are giving it free of charge through the Max Foundation. Again, people are not aware. Yeah. So we have a lot of modern treatment. We have either subsidized, free, or fully covered by SHA. They are readily available. So nowadays, well, I'm really surprised when we see patients traveling abroad going for treatment, while everything we have. At KU Referral Hospital, we have a whole unit dedicated only to breast cancer. We call it breast unit. We have dedicated surgeons who have been trained only to operate on breast. They don't do any other work. Their work is just to operate breast. So for us, we do like more than 300 surgeries. And nowadays, the kind of surgery we do, we don't remove the breast. That's why we really emphasize on early detection. If you come early, the breast lump is very small. We can just remove the lump we maintain with your breast the way it is. Before it was not possible because we used to remove everything. So you don't need to lose your breast because of breast cancer. We can just remove your lump. But even if we remove your breast, in many hospitals in Kenya, we have what we call the plastic and reconstructions, including KU Referral Hospital. So we can do reconstructions. After that, Vivian, we are going to reconstruct your breast. You become even better. They look even younger, even if you're old. And you're going to, people are going to be wow, like, oh my God, is this the same Vivian? Yeah, so these are the things available.
That is really good to know. And you know, even as it is normally said that my people perish because of lack of knowledge. So it's really good that we got to have you here so that you can just spread the awareness that what we need to do, number one, ensure we do the screenings. Just go for screenings. You don't need to feel anything. Just go for your screenings at least once a year. And then the other good news is that even after you get diagnosed with this cancer that is breast cancer, we have institutions, hospitals right here in the country that can be able to give you the proper care that you need. And we have the state-of-the-art machines, just as the doctor has mentioned. So thank you so very much for spreading the awareness.
Thank you.
It was a pleasure having you on the show. This is where we get to end this conversation. I wish we had more time, but I mean, you're here so we can still have you over and over.
If just one second, if you allow me.
Yeah, okay, so, very quickly.
Yeah, so like today and tomorrow at KU Referral Hospital, we are offering a screening camp, free screening for those with SHA, those with cash, 50%, those needing biopsy, and they're needy, we are going to offer it at free of charge, courtesy of our partners.
All right, there you have it. Thank you so much for watching.